Hello, good morning for you, Beth and Meghan. Thank you so much for joining CareOps and talk about the amazing stuff that you're doing at Premise Health. We have, I think, 200-ish people that signed up. Many more will watch the recording. So a lot of people are excited in understanding how you did what you did and how you came, or the journey that you went through in achieving the scale that you have. So maybe what would be extremely helpful if you can, maybe starting with you, Beth, can you, before introducing Premise Health, can you maybe first introduce yourself, your background, and how you ended up as the COO of a cool company like Premise?
Sure. Thanks, Rick, and thanks for having us today. I am Beth Ratliff, and I'm the Chief Operating Officer at Premise Health, and I oversee enterprise integration of our business processes, technology, client success, and clinical service delivery. And really, we are focused on driving enhanced experiences for our members, being more effective with the care that we deliver, and more efficient. And we serve about 10 million members, so very important mission that we have here. I started out my career as a physical therapist in one of our centers, actually caring for members, and quickly discovered that I was much more interested in the administrative side of the house. How can we be more efficient and effective? And really help those therapists who were really great at what they did. I was an average therapist, but really help those clinicians who are great at caring for members be even more effective.
Awesome. And what about you, Meghan?
Sure. Thank you. Thank you for having us. My name is Meghan McManama. I'm a nurse practitioner by training. I'm certified in adult and women's health. And I am Premise's Vice President of Product. And I oversee the team that's responsible really for the evolution of the services that we provide, from primary care and occupational health to behavioral health and physical therapy and other musculoskeletal services. Like Beth, started as a clinician. Before I was at Premise, I worked for a number of different hospitals, accountable care organizations, patient-centered medical homes, and came to Premise about 11 years ago to work as a clinician, a nurse practitioner and health center manager at one of our locations in Boston, which is where I'm located. And over the years, really just saw what an amazing offering Premise had in disrupting the healthcare environment and serving patients so much better. And so I stuck around, and we're really excited to talk to you all about what we do differently and how we do it, especially at such a large scale.
It's very impressive to see that, as like both of you started as like a clinician in some way, and then you worked yourself up. So like the internal promotion it seems like pretty strong, which I love. And also the fact that we have 3 clinicians on this Zoom or panel also makes me very excited. And then so maybe Beth, to you. So you mentioned like you deliver care for 10 million eligible members. What is Premise? Like, what care do you deliver? Can you like briefly explain to the audience what it is that you do exactly?
Sure. So we are the largest advanced primary care and direct healthcare company in the country. We operate about 850 wellness centers and pharmacies, and we do that on behalf of large and jumbo self-insured employers and unions across the United States. And our services are delivered in person through a combination of bricks and clicks. So our bricks and mortar locations are actually located on the employer campus where members work, and in the communities where they and their family members live. And then we also operate a 24/7 on-demand digital wellness center that is coast to coast delivering care. I think for those on this call or listening to this podcast that aren't familiar with direct healthcare, organizations like Premise, we only serve our clients' employees and their family members, so we aren't open to the general community. And unlike a traditional healthcare provider, we are fee for service, so we aren't getting reimbursed by the insurance company based on the number of patients we see or the number of tests we order or perform. So we're paid directly by our client, not the insurance company. And we focus on value over volume, and ultimately we're paid for delivering on improved health outcomes and lowering total cost of care. And that's not just for our client, but the total cost of care for our members as well.
And so you already touched upon it like many times already, like you are really centered around like a better experience. And when we spoke, I think Megan, it was you that mentioned like this is also our North Star for both patients and providers. So can you like maybe explain like what is the North Star specifically, and how do you communicate that to, for example, the clinical team when you are a nurse, or when Beth was like a physical therapist? How can they see and track that North Star, and how do you keep track on like this is indeed improving over time?
Sure, great question. I mean, our mission as an organization, our tagline, our mission is to help people get, stay, and be well. But I think our North Star, the best way to describe it is it's all about better experiences, better health, right? Actually, we want you to be healthier, and that better value that Beth was talking about. So not providing the fee for service. So we're not disincentivized or only incentivized to provide certain complexity of care. So to provide that to what we really want to be doing is providing that high value, high quality care to more people. We call them members, because as Beth mentioned, it's not for the general public. So for our members, we want to provide more care to them with top tier experience. And then behind the scenes, we have these infrastructure teams that are incredibly important to the actual clinical care teams members' success. So for those nurses, physical therapists, physicians, behavioral health professionals, psychologists, psychiatrists, all of them, for them to be able to focus on doing the work that they do best. We have this really robust infrastructure that creates, automates, and trains our field teams and our operators on different dashboards and notification systems for the site leaders of when things are, who's not meeting what target or metric, or who is overdue for some appropriate screening for them based on their age or their sex or their medical history. By having that infrastructure, that allows those clinicians, which is the people part, and using their education and their knowledge, to focus on what they're doing best, which is actually helping to take care of people. I think at the core too, is we're really looking to provide better access for people. It's really hard to get healthcare in today's environment. You might decide you want to take care of a medical issue that you've been thinking about for a while, and then you hit a brick wall to find out it's going to take you 9 months to get in with somebody. And so we want to not only engage members and their families and say, this is the care that you have available to you, but also we can see you today, we can see you tomorrow, we can see you, we can get you scheduled with the whole care team within 2 weeks. And so by having those multiple access models, whether it's video visits, in person, telephone visits, secure messaging, and just doing everything asynchronously with some patients, we can meet patients where they are at the time and where they are when they need it, which is a big differentiator for not just for that patient, but also for our clinicians. So it's a balance really of our North Star is the balance of the access to care, but it's care that is high quality, high value, and really just lovely, and an overall nice experience.
Yeah, Megan, I think when I started, in that center so many years ago, and they told me, don't worry about whether this is covered by insurance. Insurance isn't paying for this. You worry about getting the patient well. And if you deliver on health outcomes, then you have met your goal. And that was such a radical change from coming from the community, where it was all about, will insurance cover this? How many visits will insurance cover? Did I get my coding exactly right? And so they had me at hello, and they said, take great care of the patient. Everything else, we've got you covered. And I think when I talk about our North Star, and I talk about what does it look like for the member, it's same day appointments in convenient locations, but it's also less time waiting in the waiting room. So our wait times are on average less than 5 minutes. And it's a lot more time in that exam room with the provider, getting to know and trust the provider and developing this personalized care plan. So our providers on average spend about 30 minutes with the patient. It also means you have this care team approach. So you have access not only to a doctor or an advanced practice provider, but also a behavioral health therapist, a pharmacist, a care manager. And if you need that referral into the community, it means that we have a concierge care navigator that's going to use data to identify those high quality, high-value providers in the community that are in your network. They're going to make the appointment for you, make sure you go to the appointment, and then close the loop on the back end. And so, members don't have to be on this healthcare journey in a very confusing ecosystem alone. That ultimately, that experience that I just described is what allows us to deliver, at 95th percentile HEDIS measures, those clinical outcomes, and ultimately what lowers total cost of care. And so it's aligned incentives for patient, provider, and payer, which in our world, the payer is the client because they're self-insured.
Yeah, I really like that. Especially like you see like many companies that like try to do different things in healthcare, like for example, telemedicine companies or VC-backed companies. They raise a lot of money, but then essentially what they do, like from an access to care perspective, it still takes the same time to book that appointment than it does with my PCP. So why would I be interested in using your services? And so I'm really bullish on the idea, like if you can accelerate time to access, then you also improve the experience for the patients drastically as well. So I really like that as a North Star metric. Now, something not really related to that, but something that really blows my mind is the fact that you scaled your care delivery to so many different employers and so many different clinics. Like when I talk to companies that serve B2B as well, they always complain about the fact that different employers want different care pathways or different thresholds. So let's say, for example, mental health, you launched something in behavioral health recently. So I sell to Meta and they say like, okay, when you have a PHQ-9 of 15, then I need to do escalated to the clinician. But then I sell to Microsoft and they say, no, the threshold is, for example, 10 instead of 15. So how do you like make sure that there is some standardization, but also making sure that your sales team can actually sell to these employers? Like what's your philosophy there?
It's such a great point. So I think Stu is our CEO, and I've heard him say probably, I don't know, 500 times now that if you've seen one of our health centers, you've seen one of our health centers, right? Because part of it is with the client as the customer of what we're putting together, we make recommendations for them based on what the problems are that they're trying to solve within their population. What's your claims data showing? What are you hearing from your employee population? What are you seeing? Depression screening is a really good example of why interdisciplinary care is so important, because you will see PHQ-2, which for those of your listeners who are non-clinical, a PHQ-2 is a 2-question screening tool to look for signs of depression in an individual. And if either question is positive, it bumps you up to a PHQ-9, which is a 9-question. And then you add up all the points for each question and you get a score. And then you have to do something with the score. And they're either, from low risk to very high risk. The standards, the thresholds the example that you gave, we don't modify. We defer to what's the evidence-based best practice? What are the professional bodies saying we should be doing? American Family Physician, AMA, the psychological organizations. What is the evidence-based best practice? What our clinicians do with that member based on their result is where we see some differences. So for example, at a patient-centered medical home that has they don't have a behavioral health provider on site, but they have access virtually through one of their vendor partners. What we do with them might look a little bit different than if they're one of our advanced primary care clients and they have the therapist, the psychologist, or the counselor down the hall, right? When it's in our health center, it's a warm handoff. It is, patient, I know we're dealing with this today, but I really want us to talk about your score on your screening today. And we have a conversation with them of what their needs are. We get to the bottom of it. All of our providers are trained as behavior change generalists. So we partnered with Well Coaches, which is our national certifying body for our health coaches, to create a custom program for our providers, for our primary care providers, our pharmacists, all of our different clinicians, so that even if you're not a coach, we can do some of this motivational interviewing, some open-ended questioning to work with these members. And then we can say, I'm going to walk you down the hall and I'm going to introduce you to Dr. Drozd, and he's our psychologist. And we're going to do a warm handoff to get that person established with care, as opposed to, I don't even want to talk about these scores because I don't know where to send this person. And I might say, you need to see someone but you're on your own in finding what's covered in your plan. And so many behavioral health providers now are not taking insurance or have these long wait access times. And that's, I know we probably have an opportunity to talk a little bit about how we developed and expanding our behavioral health offering over the years, but having that integrated care team really allows us to do something for that individual at that point of care. And all of that is part of our really robust onboarding, but also continued support for those clinicians, whether they're primary care or behavioral health or other. We also have them all documented in the same medical record. So we use the Epic electronic health record, and we follow, there are certain privacy guardrails that we follow that are standard nationally for privacy purposes between behavioral health and primary care. But there are allowances in there for those clinicians to message each other securely, to share some dashboards so that the primary care who's managing the diabetes and maybe the anxiety meds can communicate with the psychologist or the counselor who's doing their biweekly therapy to make sure that what we're prescribing is working, or making sure that they are getting better. Or if there are side effects that we need to know, we can work with our clinical pharmacists to make modifications of their medications. All of that is possible because we're documenting in the same electronic health record, and we're one care team, and we don't have to worry about things like reimbursements and time spent with a member.
Meghan, I love how you just described it. And I think, Rick, from a sales perspective or a conversation, we sell on outcome measures rather than process measures. So we will report, and we have some variability in how we report on process measures. So if one client wants to see a report, based on a trigger of, a level A, and the other client wants to see a report based on a trigger of level B, we can build some variability, intentional variability, into the way that we report process measures. But ultimately, clients are partnering with us because we're improving health and we're lowering total cost of care. And those are much more, we can demonstrate that with the data, and we lead with that. So what we lead with is we use clinical best practices. Here's how we measure clinical quality. Here's how we measure outcomes. And here's how we measure the value of what we're delivering. And if you want to see that reported slightly differently, we're all over that for you. But we aren't going to change our clinical best practices in order to, if you want these outcomes and you're partnering with us, this is what data has historically and consistently at scale shown, demonstrates, and will get you the value and the outcomes that you're looking for.
Yeah, I really like that, because often the knee-jerk reaction is like, okay, let's just give it to the employer because we want to sign that contract ASAP. But the first principle approach would be like, why do you want to change the threshold? While we have all of this evidence showing that if you change the threshold, it might negatively influence the outcomes, and we already have like the valid outcomes there. So maybe the learning here is more like, from a clinical leader's perspective, is like, don't say yes too soon to the sales team, and just like think from a clinical perspective, like, we have developed these protocols for a reason. So why should you, as like a benefit decision maker on the employer side, make the decision to change those protocols that we know work very well, which I think is a very solid learning, and something that we need to keep tight more as an organization or as an industry as well.
Rick, I think one of the other things that one of the other feedback for members for our clients, that we can leverage too, is that you don't just have to take our word for it. So when we say we follow evidence-based practices and professional guidelines, we also have our clinical quality vetted by a third-party organization. So, any of your listeners that are involved in the ambulatory world probably know who the AAAHC is. Think of the ambulatory sibling of JACO, right? But so the AAAHC is who we partner with to provide our accreditation. And we have over 100 health centers that are accredited through our AAAHC process, through our multi-site accreditation process. And they have, part of our partnering with them is that they can come and they can do an audit of our sites and do a survey. And for many, many years, we have had very successful surveys where we're showing them our QI studies. We're showing them where we scored well or fine, and what we did, and where we now have really high scores. We show them our processes for near misses and incident reporting, and what we've done systematically to change our processes across those 800 health centers to ensure that our patients are safe, that our care teams are safe and are providing the best care, and that we have those kind of in between visit close the loop processes, so that folks are not getting lost out in the ecosystem, our healthcare ecosystem, because it's hard enough for our clinicians to navigate it, let alone a patient who is trying to manage their life and their family and their job.
Yeah, I really like that. And then in terms of learning, so you indeed have like these workflows that have standardized, but then you indeed, based on certain nuances in the workflow, the way that you engage with a certain employer, there are also learnings that you want to share across all of these practices. So how are you able to break the silos between those practices and share some of these best practices? Yeah, it's too many practices, but I think you get the point. Like, how do you make sure that different employer providers learn from it? Do you have like an intranet? Do you have like monthly learnings? Like how do you think about the continuous learning of your provider workforce as well?
I mean, so they don't get overwhelmed.
Yeah, I mean, we take kind of a multi-pronged approach to what we don't do is open a health center, in California, and then they're just doing their own thing. So they are part of the Premise Health ecosystem, and they are supported by, first of all, regional and local clinical and operations support teams. And they have, robust training, routine interaction. So that can be, written communication, phone calls, Zoom meetings. We use dashboards to monitor the quality and ensure that, from a KPI perspective, they're, following process. We're looking at those dashboards often in real time, so we can see that there's a center right now in Kansas that has a wait time that's exceeding where we want it to be. So we're able to, from a centralized perspective, really quickly intervene, coach, monitor, support those teams that are delivering the care in those centers, no matter where they're located. And then we also bring teams together to share best practices. So it's not unusual for a group of providers to be on a call, kind of doing grand rounds together. They may be in different states, serving different clients, but they're all sharing, best practices and learning together. Meghan, I know you've been a part of that clinical team. And historically, you want to talk any more about how we do that?
Sure. I think so there's the grand rounds. We've got regular pod calls, we call them, where we can group like medical directors or clinical leads from like sites, whether their client is in the same industry or they're in the same geographic region. But regarding our actual care processes, we've been very fortunate in that we have a lot of really stellar clinicians and care team members that have, similar to what Beth and I have done, right, started in some of our health centers and grown up in the organization to move into product manager roles or clinical operations managers or directors. And so we've created this really robust library of resources, whether it is algorithms and standards of care, if it is programs like Lunch and Learns, things that our clients and the communities have asked for, smoking cessation programs, or mirroring the success of the diabetes prevention programs that you see. So when we have these libraries, so no one at our centers has to create something from scratch. And then when there is a novel a new need in one of our centers to create something new, our centralized team, our product managers or their clinical leadership teams partner with them to make sure that what they're creating is representing what Premise would want, right, as in terms of our evidence-based best practices and standing with our guardrails. And then if it's successful, we standardize it and centralize it so that other sites can learn from their learnings, right? So no person is on their own. Similarly, in our electronic health record, if we have smart sets or smart phrases, things that have been built into the electronic health record to make the clinician or the care team members' job easier so that they can spend more time taking care of the member, we can centralize them so that and deploy them to all of our locations, all of our centers. So that really helps to augment the amount of time that our teams have to be researching and creating their own or becoming an expert of all these many things. So really it's about front end optimization and also back end streamlining and optimization, so that, you know, when we identify issues within our client population, we can tag one of our subject matter experts, we can pair them with the clinical team on site to create something for them, and then we can expand its availability to all of our other care team members in the field.
Yeah, that is that all makes, again, a lot of sense, and also what I've seen in the space, but obviously not the scale that you are doing. What's also interesting is you recently, I think in June, you launched like fully integrated collaborative care for behavioral health, I think what it's called. Now, collaborative care, maybe we can start with that. Like, Beth or Meghan, can you briefly explain like what it is and how it is incorporated into how you deliver care, and then we can talk about the model after that a little bit more in depth.
Sure. I think kind of going back to what I said earlier, you know, when we talk about advanced primary care, it includes not only what you think of as a traditional primary care provider, but also a behavioral health provider and a pharmacist, you know, dispensing medications, filling scripts, and the clinic and fulfilling the clinical pharmacy side of the house. They're all working together along with a care manager to care for the whole person. So we think about it as addressing physical, mental, and social needs. And so whole team approach, caring for those members' needs. And, you know, when we developed this model, the collaborative model, which I think I'll ask Meghan to go into a bit more detail about, we really took a data-driven approach. So what we evaluate when we launch a product, we're really looking for, is it positively impacting experience, effectiveness, which are our health outcomes, and is it impacting the value of care that we deliver? And what we've seen through repeated third-party validated studies is when you have the combination of the care team that I just described, really delivering accelerated value, so more savings to client, more out-of-pocket savings to the member that we're serving, and better health outcomes. And so that's kind of what led us to kind of this collaborative model, and would love for Meghan, as the clinician on the phone, to talk a little bit more about what that looks like with our behavioral health model.
Sure. Thanks, Beth. So our behavioral health product itself, so having counselors and psychologists in our centers in the field, started about a decade ago, and it really ramped up, not surprisingly to any of your listeners, probably during the COVID pandemic. Not only did we see a rapid adoption of behavioral health services at that time, but we also saw an increased need in not just that in-person care, which is historically what we were seeing in behavioral health. You come in, you sit down on the couch, and you have your visit with the clinician, right? So we saw a real ramp up in our virtual services. We've grown that product, and we saw during I think in 2020 to 2023, we saw like a 550% increase in the utilization of our behavioral health professionals. Huge ramp up. And it really hasn't gone down. The only thing that's really stayed steady is we have not seen the full return to in-person in behavioral health that we saw in primary care and some of our other services. Over the course of a few years, we have added standards of care and expectations for our care team members in behavioral health. CAMS is a certification that behavioral health professionals can get to address individuals who are suicidal. And it's an actual treatment program. And the idea of it is to get suicidality symptoms under control and reduce just referring everybody to the ER. Don't just call 911 or 988 on everybody. You know, it's for behavioral health clinicians, so it's not for other primary care clinicians. But we implemented that training a few years ago, and it was so successful that we decided to make it a requirement for all of our behavioral health professionals. They must be certified. And for new hires who haven't been certified before, we give them a certain amount of time and CEU dollars to get certified. And last year, we were recognized by the AAAHC. We won something called their Bernard Kirshner Award, their People's Choice Award, for that commitment to implementing change in the care delivery and what we do. And we've seen it very successful because, as you know, mental health crises have been on the rise over the last number of years, and access to care is so important. And sending everyone to the emergency room is not the best solution for so many individuals. And so, building upon Beth's answer before, really, despite improving and increasing the amount of services that we are providing in behavioral health, we were still seeing challenges with access to psychiatry. And so, whether it was long waits for appointments or really high out-of-pocket costs for patients, and because of the transition for so many of those clinicians to out of accepting insurance and into private payments, that was not only driving employees to escalate issues to their benefits and their HR teams to say, we can't get mental health services for ourselves or for our family, especially for, and for children. But it also forces so many families to go without that care. And just like in primary care, the longer you prolong care, the worse the condition can get. And so it increases the acuity, the level of acuity that the person enters the treatment, the diagnosis and treatment cycle into. And it's more disruptive to their life, but also the cost of their care goes up, right? So if you're going in through the ER, or you have a much more complicated mental health diagnosis because it's been simmering, right? It's been festering for a really long time. And so you might find that someone needs to be hospitalized by the time that they're coming in to care, as opposed to earlier on. And so because of that increased need, we implemented psychiatry services at a few of our health centers. We saw really great engagement right off the bat, and great collaboration between the psychiatry providers, the psychiatrists, and our primary care providers. And so it wasn't just our patients who are saying, oh, great, I don't have to wait 9 months to get in with someone. I can get in with someone now. But as a fellow nurse, as another clinician, I'm sure you feel this way too, but there's nothing worse than feeling like you can't do anything for the patient sitting in front of you who needs something, right? And being hampered and handcuffed by the access to care. So we built out those services in also service of those clinicians on our care teams, to give them the tools that they need to do their jobs. And I think it's worth calling out that, so we put these psychiatrists and these psychiatry clinicians in a few of our centers, and it was super successful, not only to provide direct patient care, but also to provide consultative care and collaborative care with the primary care clinicians that they're supporting. So there is a little gray line in behavioral health services in primary care of what's diagnosed and managed in the primary care environment. Many, if not the majority of individuals, are getting their SSRI prescriptions or getting their anxiety and depression medications prescribed and refilled by their primary care providers. But it's often that the primary care providers, especially with people moving around the country or moving jobs or moving primary care offices, that the primary care provider is saying, I see that you're on this medication, or you used to be on this medication, but I want to make sure that this is the right diagnosis, or I want to make sure this medication is a good fit with all the other medications you're on. Being able to consult with a psychiatrist on staff in office is an invaluable resource. It is, and it mirrors the collaboration that you see in a lot of hospital systems, but you don't have access to in primary care and ambulatory centers. And so we're able to provide that. But it is really worth noting this is an evolving process. This is a newer product for us. Behavioral health has been around for a really long time for us, primary care for decades. But as we're adding more of these psychiatric providers into our service offering, we are finding new and different ways that we can integrate them and have them collaborate with our primary care providers, with our care management nurses, with the behavioral health professionals that might be doing the weekly or biweekly or monthly therapy, psychotherapy with members. So we'll continue to identify opportunities for improvement in our electronic health record, in the standards of care that we put out, similar to the, you talk about care ops and improvement and rolling things out. think back into the PDSA, not to give anybody PTSD from graduate school, but, the plan, do, study, act, constant, the cyclic nature of implementing programs, reevaluating them, making sure that they're working, and then modifying them. We have tested and modified even in the short couple of year or year that we've been doing the psychiatry program product. We've modified our talent acquisition process, our interviewing process. We're revising our job descriptions, requiring and modifying some of the training, like the CAMS training, because we see what works. Even our scheduling templates with our primary care providers, making sure that we're building in care team time so that the primary care providers, the care management nurses, the behavioral health professionals can have time to meet, especially on those really complex patients, and not get dinged, if you will, for their utilization being lower, like we would see in a fee-for-service model, like, oh, I don't have time because I have to churn patients through my schedule. Our clinicians, because of some of the care philosophy and the scheduling operational philosophy that Beth went over earlier, we don't have those same restrictions, and so we can really build in that collaborative model into the infrastructure and the backbone of our health centers.
Meghan, I think as you talked about CAMS, it's important to note that not only do we get our providers trained and certified, but we've built an integration into our electronic health record so that it supports the workflow of CAMS. And we really focus on, how do we make this as seamless as possible for the providers who are giving care. We don't want them having to go to multiple places to get information. We want there to be nudges and notifications and directly in their workflow wherever possible. And so CAMS is a good example, but another great example is the Find Help interface that we built. So we have a social determinants of health database that we've fully integrated into the electronic health record. So we're assessing our members for social drivers of health needs, and then they actually have a database where they can search by zip code to identify resources in those members' communities that can assist them with those social drivers of health. That could be food insecurity, transportation, domestic violence. So again, we know through experience that if you give a provider a tool, but they have to pivot out of their traditional workflow to go use that tool, they have to log in somewhere else, go look up something else, remember that there's a tool, they're less likely to use it. It's just not, as effective and efficient. And so we do everything we can to build all of that directly into their workflow. And there's 1,000 other examples of how we've done that.
But I might add, Rick, earlier, because you had mentioned, how do those clinicians not get overwhelmed by all of these resources that are available to them? That's a really good example of the constant communication that it requires with our teams to listen, not just cascade information to them, but listen to what the pain points are. Because when we're leveraging, I worked in primary care before I came to Premise, and one of the hardest things was, I don't know what you have access to, either through your employer or your benefit plan, or, you're seeing somebody in the community. I know what you have access to in my hospital system. When our teams are embedded in a client culture and environment, we train them up on what's this population's benefit plan? What other vendors do they use? What premise health services do they use? And we want them to be experts in the services that the members have access to, so that at the point of care, I can say, oh yeah, you need a smoking cessation program? I can have you meet with our coach or your plan provides this service or this free medication. They know these things at the point of care, but taking it that even up a level, not just knowing what they have access to, but then knowing what they have access to within their zip code at their home with Find Help. It's like having a social worker in the exam room with you to say, oh, I know that social drivers, if you can't afford your medication and your groceries, you're certainly not going to be able to afford a gym membership and I'm going to talk to you about your physical activity, right? Or if you can't afford to get to work on public transportation, or you have a child who has a mental health crisis and needs inpatient services, me sitting here and talking about, what are your goals for the next 3 months? That patient is totally distracted by what's going on with their child. So as the primary care provider, the clinician can put in the individual zip code. It's integrated within our electronic health record, but it's also accessible just on the web. And the members can look at it from home as well, or through our patient portal, and can see what services they can get in their community for their child, for food insecurity, for housing security, for transportation. And we can start to work to address some of those social drivers of health so that the individual can then focus on what we're trying to work with them on their physical and their mental health.
Megan,
so,
I'm sorry, Rick. I was just going to share with you all. I just got a patient success story this morning in my inbox, and it was a provider who was seeing a member, and she had some chronic health issues, but seemed very distracted in the exam room. And it turns out her father, homeless, living in a different city, she was just worried about, it's getting cold, and he was, he didn't have any shelter. And literally the provider stopped what they were doing, helped her find some resources for her dad who lived in a different city. And she wrote back in and said, he slept in a shelter last night because of the help that you gave me. I'd like to make another appointment to come back in and talk about my health condition. Like, she could now think about and focus on. And so we literally cannot get people better. We can't help them get stay and be well if we're not addressing really what's going on with them. And sometimes what's going on with them is larger than just the patient sitting in front of you.
yep, I really like that example, and that's obviously the benefit that you have is that you don't need to think in fee for service, but you indeed have the flexibility to
Yes.
go way beyond for the member. In terms of like going way beyond of the member, like one of the things that we see often is like you have charges, and then you have CEOs that want to like improve the bottom line and they think about automations, but obviously not everything is like is suited for automations. So were there like any processes you assumed like would be ideal for automation, but later realized like were better handled manually?
Oh gosh, we learn something every time we implement. And often we think this is going to be great. This automation is going to be great. And we find that, there's just too much complexity, or often it's just not what the member wants. It doesn't deliver the outcome that we're looking for. So a couple of examples I would share, several years ago, I guess it's been almost 8 or 9 years ago, we transitioned to Epic. And so at the time we had 6 different EMRs we were using. We had 4 different patient portals. And we went through this process to move everyone onto Epic. And it was an 18-month process. And it was a heavy lift. And we had some grand ideas about how we would leverage Epic technology in the process. One of the things that we really thought was that we would use kiosks and self-check-in to improve efficiency. And what we found is that for the most part, even at our high-tech clients, so, think those West Coast, Silicon Valley clients who are very tech, they're tech companies, they don't love using check-in like that. They want a person who greets them warmly, who knows who they are, to facilitate a very personalized, high-touch experience. And what we also know is there are a few who still want that tech, so we offer the high-tech and high-touch. We automate it for those who want to use that, and then we also offer that personalized experience. And we've seen that throughout, kind of the history of Premise. Some of the other things that I would say is that oftentimes clients will think that they want a dashboard so they can see real-time reporting themselves. And we have those dashboards available to our clients. They rarely get used. It is a rare client who actually logs in and looks at the data. Ultimately, what they want is a consultative approach, someone to review the data with them, to talk about the so what, to come with informed recommendations. So this was another place where we had high hopes that we were going to build this self-service model. we were going to really satisfy what our clients wanted. And in the end, the clients didn't exactly know what they wanted. And, we've iterated over time to again, offer that balance of high touch and high tech.
And so in terms of like looking back, like the things that you scale, because you gave some very good examples, were there any aspects of scaling that you didn't fully account for? Like maybe like underestimated, like that this will become a bottleneck pretty soon as well?
Yes. I think over the years, and you touched on it a little bit, Rick, in the beginning, over the years, we've learned a lot, but one of the things that we've learned is that we are too quick to say yes sometimes. When a client asks for something, we will, without fully understanding the objectives, what are they really trying to achieve, we will build a one-off solution. A variability, we put variability into the model that then, creates a drag on the system as a whole, because everything downstream from that variability has to change. The way that the workflows are built, the way that the monitoring and triggers are built, our centralized dashboards, everything changes. And so I think if I had it to do over again, I would say we should have built earlier on more rigorous governance processes so that we can collectively and collaboratively understand what are we trying to achieve, and then build a process that is scalable. Because it's rare that at the high level that a client is trying to achieve an objective that another client would also want. But what we have ended up with historically is 2 or 3 solutions that are trying to get at the same goal, and it's just not scalable. I would rather spend the variability in places that matter for clients rather than variability that doesn't really deliver value.
And maybe last question on like the lessons learned. Was there like anything, like if you look back at, I think that you've been at Premise for 15 years, maybe longer. What lessons do you wish you had known? Because we have people here that are starting a journey in solving primary care or solving some part of healthcare. Like what are like some advices or lessons that you would want to give them to like not make the same mistakes that you and the teammate when scaling?
I think I'll go first. I'm sure Meghan has some ideas as well. I think for me, it is, if I can make a recommendation, it's be brutally focused. So, I always say to my team, just because we can do something doesn't mean we should do something. You have to really ask yourself, if we're going to change a workflow, if we're going to build something different, is the juice worth the squeeze? Are we going to achieve what we're setting out to achieve? Is the level of effort kind of worth it and going to give us the impact that we're looking for? Because what I know is that there's limited time and resources and money for everything. And so when we say yes to something, whether it's building something new or tweaking something we already have, ultimately, that means we're saying no to something else. We can't invest in something else. We don't have the resources to apply to that. So really keeping your teams focused and keeping in mind that when you build something new, it's not just, okay, we've got a new product. You're going to have to implement that product. You're going to have to train the teams on that product and that workflow. You're going to have to build controls and monitors and reports. And so, really understanding what is all encompassing about the changes that you're about to make and being very intentional about those. Meghan, anything you?
Yeah, Meghan, what about you?
I think starting with the end in mind is really helpful. I think, we as an organization, Premise has been around for a really long time. We all know that there are a lot of newer organizations and companies that are out now that are starting from a more maybe at the onset technologically advanced, or they're solving one problem that is current right now. And so when we have a very, very wide foundation of problems that we can solve. And so when we're adding something new, it's really helpful for us to pause, and we work in a very matrixed way. So, a team member from multiple different departments, we try not to silo, will be to get work and meet together very regularly to talk about things like this, like new products or product evolution, and say, what is the end goal? What are we looking to build? And then backing out of it and build the process and implementing the technology, the people, the processes that we need to get to where we're trying to go, or what it is that we're trying to do. And by working with those kind of interdepartmental leaders or individuals, we can make sure that we have the data that we need to do it. The operationalization is possible, that the care delivery at the point of care is still possible to still meet that desired end. I also think for the leaders, and this is the person, whether you're running the project or the program, or you oversee the teams that do, it's really helpful to understand the end-to-end process of implementing something new. You don't need to be the expert, depend on your subject matter experts to drive all the nuts and bolts of how you do it. But having a high level understanding of the process without getting too far into the weeds, it can make a really big difference in understanding not only your timelines, but where you might hit some challenges. It also reduces the likelihood that, if you don't have a full understanding of the processes, you're more likely to have errors, have political missteps, have some inefficiencies that can really slow down your drive to get to that new product or that new service implemented. So I think if you're the one leading some sort of a transformation or a new process flow or care op, it's really important to have that full understanding of how each part of the process functions to make informed decisions about who's supporting it, how many resources you're allocating to it, so that it can hopefully get implemented with as few disruptions as possible.
Meghan, one of the biggest frustrations in my career has been implementing what I think is a really valuable product. And because we did not start with the end in mind, we can't measure the outcomes. So nobody said at the beginning, how are we going to measure if this is improving experience or efficiency or effectiveness? And so we end up with a lot of use of the product, but we weren't tracking. We didn't set up the systems in the way that we needed to really measure it so that we could continue to improve it. So I think that's a really critical piece. The other thing I'll say, and I know we're almost out of time, I know there's this popular idea more in the tech world of like move fast and break things. And that's exciting, but we are in the business of taking care of people. And so we need to move fast, but we can't break things. We have to get it right when we're delivering clinical care. And so sometimes it's okay to slow down a bit and make sure that you have it right, because there's too much risk in breaking things and the delivery of care.
It's indeed a very important message as well. So we only have 3 minutes left, and I want to ask like a very short question, and you don't need to overthink it or like add a lot of context, but like gut feel. Just because I'm interested, we talk like a lot about data and outcomes and all of that. You as like the COO, what does the dashboard that you look at every day, what does that look like? Or like 2 metrics that you look at every day? Is it something else? Yeah, that would be really interesting.
I look at an internal performance analysis dashboard on a daily basis that looks at key process indicators for the centers. So it has access measures, experience measures, and clinical outcome measures. Those are kind of from an operational perspective, and then I also am looking at financial performance on another dashboard.
That's cool. Meghan, do you look at any product-related metrics, or do you look at the same metrics that Beth looks at?
I look at both. I do look at those within that internal performance analytics dashboard. I can look at the product specific, so I can look at other performance of the primary care product, the behavioral health, the musculoskeletal, the KPIs that we set for those communities of clinicians in the field. Also look at our pipeline reporting to see not just what business we are winning, but where we are not, or if we are not just what we're winning and we're not winning, but what are we being asked for that we don't have? And that was probably the example of saying, having a controlled response to hey, could you do this? Pausing and saying, well, what's the problem you're looking to solve? Because even though we might not do that thing that you have asked for, do we have another solution that actually fixes that? There is a solution to that problem, and this is why we do that. So I think those are probably the dashboards that I look at most commonly.
I love it. I love it how data driven the entire organization is. We're just in time, so time's up. Thank you so much for sharing all this wisdom and expertise. And yeah, best of luck in scaling Premise to 20, 50 or more million patients in the next decades to come.
We're growing rapidly. We are on that path. Thank you, Rick, for having us today. It's been fun talking about this.
Likewise. Thank you so much.
Thank you.
Have a wonderful day. Bye-bye.
Bye. Thank you.